Hello, I'm Dr. Jodie Richardson, and you're listening to, well, Hello Anxiety, a podcast where we end the struggle with anxiety and build our toolkit of practical skills to thrive. Uncertainty, lockdowns, school closures, isolation, loss of control, social distancing, and the stress related to the virus itself have, in combination, profoundly affected the mental health of children, teens, and their families, and many, many others. During this time, there's been a rise in explosive onset tic-like behaviours. The tics are both frightening to experience and for everyone who loves and cares for the child experiencing them. Here to help us understand more and what families can do and where to reach out for support is the wonderful Dr. Amanda Maxwell. Amanda is a registered clinical psychologist and has worked in child and adolescent mental health services, otherwise known as CAMHS, in the UK since 2005. She's now here in Sydney in Australia and continues to support young people with their mental health and wellbeing, anywhere from moderate to severe mental health difficulties, including anxiety disorders, depressive disorders, phobias, obsessive compulsive disorders, and she has a special interest in working with young people with Tourette syndrome and is here to share her wisdom, experience and expertise with us. So Amanda, thank you very much for taking the time out of your very busy schedule.
Pleasure. Thanks for having me.
Thank you. Could you please start by telling us what is Tourette's, what are tics, and what's happening in the body and the brain?
Well, tics are basically repetitive, sudden, non-rhythmic movements or noises that are considered largely uncontrollable or very difficult to suppress. They're considered a neurodevelopmental movement condition, so it is something that presents in childhood from around 5 to 7 years of age, but some kids will show tics earlier than that. And it affects about 3-to-1 boys to girls, so it's more prevalent in boys. Tics, they sort of follow a pattern of waxing and waning, so they'll come and go. They tend to start in the face, or they tend to start as simple motor or vocal tics, so you'll get lots of little facial grimaces or movements, and then they gradually move down the body as they go through the years. So if they have persistent tics, they often start off as quite simple, and then they will, over time, gradually increase in complexity, but also move through the body, and so too with vocals. So you often have like the initial presentation might be a cough or a sniff or something like that, but over time they can increase in complexity. And I think, you know, often what people hear in the media about Tourette's is something called coprolalia, which is where people have kind of swearing tics or loud vocal tics, but those are actually not that common. There's about 10% of young people with Tourette's that will present with that because they're a far more complex presentation. So by far, most young people that present with tics will present with simple motor and vocal tics. What I should say in terms of prevalence, tics are very common. It depends on which research you look at. Initial population studies used to say 5 to 20%. I was at a conference recently and there's estimates that up to 50% of young people will present with a transitory tic, a little movement, a little eye roll, and then that's it, and nothing else comes from it. When we're talking about chronic tic disorders, so a young person that might present with just motor or just vocal, it's more like about 2 to 3%. And then if we're talking about Tourette's, which is diagnostically, it's when you have 2 motor and 1 vocal that present before 18 years of age and last longer than a year, it's 1% of the population, or even slightly less actually. So if you think about coprolalia then, and that's only 10% of that, so it's 0.1% that would present with that very stereotypical Tourette's that we hear and see in the media. So in terms of what's going on, from what we know, and there's just loads of research happening about this, but it's probably not as well researched as some other neurodevelopmental disorders. But there's 2 parts to a tic. So the first part is an urge. So the young people will get a sense or an urge. We call it a premonitory urge that precedes the tic. And there's some really interesting research from some colleagues in Melbourne looking at this. And basically what they're seeing is that urge is presenting in a different part of the brain to the tic. And it presents in similar regions that you would get urges to do other kind of typical motor responses, like the urge to blink or the urge to yawn. And so that's one part of it. So you get this premonitory urge or this urge to tic. I mean, those regions, if you want the names, are the insular cortex or the ACC as well. But then the second part of it is the tic component. And research thus far sort of suggests that's in a part of the brain called the basal ganglia. And the basal ganglia is sort of deep. It's like a subcortical structure. And really that's about the allowing or inhibiting of movement. So it's almost like the conductor of an orchestra saying, yes, it can happen or not happen. And linked in with that is a circuitry that links the cortex, so the outer regions, with the subcortical areas. And that circuitry, it's kind of got a big fancy name, but it's the CSTC for short, is basically an inhibitory control network. So it's the stopping system or the braking system. And so too is the basal ganglia. And basically, the research is suggesting there's inconsistent braking. So it's allowing through movements or sounds that for those of us that don't have tics, we can stop. Our brain would stop it before it comes out. So you have the urge to tic and you stop the unwanted movements or sounds. And so that's kind of what's going on in the brain of what we know so far. There's certain chemicals involved, like excess dopamine and a few others like GABA. But, there's loads of research going on to try and understand what's going on and why it's happening.
Is it related to inheritance and genetics?
Yeah, that's a good question. I mean, in short, yes. So not every child will have a family history of it. But those that do, they're 20 times more likely to present with tics. Yeah, so particularly, but it's not just tics, because that same circuitry that I was referring to is also involved in ADHD and OCD, because they similarly are a problem with inhibitory control, so the inability to put the brakes on behaviour or compulsions. And so if you see ADHD or OCD in the family history, there's a higher rate of tics as well.
Right, that makes sense.
It's a similar sort of network involved.
Thank you for explaining tics. Thank you for explaining what's happening in the brain and the way that it progresses over time and the age groups that are more likely to start showing these signs of Tourette's. And I'd love it if you could please tell us the difference between Tourette's and functional tic disorder, which has the predominance of it has just skyrocketed over recent years. And so I know that the research will still be coming through and there's a lot of research to be done. But what can you tell us about the difference and what people like yourself as experts in this area are seeing?
Sometimes they're referred to as functional tic like behaviours in the research. There's an annual international conference and there's been much discussion about what we call these behaviours, but at the moment I think it's settled on functional tic-like behaviours. So they're not new. When I used to work in the Evelina Children's Hospital in London in a big neurology clinic, probably 5% of our young people presented with functional tics. However, during COVID, we saw a huge increase, and it was a phenomenon that was seen worldwide. And there were kind of emails going between colleagues in London and around the world about what was going on. There's no doubt that the increased stress that our young people were on during that time was leading to an increased presentation of some of these behaviours and symptoms. We are now running a research project at UNSW on functional tics with a 10-session treatment model. And in terms of how we diagnose and differentiate the two, there's been a working body, actually a European working body, that has put together sort of guidelines on it. And they've outlined 3 major and 2 minor criteria to differentiate or to diagnose. The first of those is age of onset. So by and large, functional tics have their first presentation after 12 years of age or after 10. For most tic disorders, we see it pre-puberty in relatively young children. Functional tics, often there is no tic prior to that, or you might have had a few mild transitory tics, but not have met criteria for Tourette syndrome. They don't present with these chronic tics. So it's later onset. So the other major criteria that has been set out is that it's rapid onset. So if you think about how I described tics and Tourette's before, there's a sort of gradual waxing and waning. It starts off as simple and mild, and then they gradually increase over time. The young people that we have seen with functional tics have a very rapid onset. So you might get a few tics one day, but by the end of the week, they've got a whole range of very complex movements and vocal tics. And it's not uncommon for them to present to emergency departments. So a lot of our young people will have a history of presenting to hospital because, of course, it's frightening for everyone in the family about what's going on. And then the other criteria is that the symptoms have a sort of particular type of presentation. There's a number of different ways they differentiate, but in short, they tend to be very complex. So if you think about the simple motor tics I was describing before, like a blinking or eye rolling, the young people we're seeing with functional tics will have very complex sentences or whole body movements or self-injurious behaviours. And they don't follow the typical course of movement from the face down to the body. They tend to be very suggestible. So they might be very, very extreme and very kind of impairing when it's being talked about in front of people. But then if they're alone, they're almost not present at all. And now tics are suggestible. That pattern does present generally, but not at the extremes that we see with functional tics. And if you move attention away from the tics with functional tics, they tend to decrease quite significantly. Yeah, so they've got quite a different presentation, basically, both in onset and course, which is how we would diagnose. Some of our young people with functional tics also have other functional neurological symptoms. So things like non-epileptic seizures, or they might have sudden paralysis. So that's not uncommon actually in young people with functional tics as well.
Oh gosh, I tell you what, I can only imagine. And I watched the 60 Minutes episode that we spoke about earlier, and it just must be absolutely terrifying. And there was video footage of a young teenage girl who the onset had begun. The family had videoed it, and she was so distressed, and her family were too. And yes, like you said, there's so many presentations to the ED because it virtually comes out of nowhere. And one of the things you said before was about suggestibility. I just wanted to clarify that the suggestibility, if a child has tic attacks, was how it was referred to in that particular interview and that report. If a child has a vocal tic, for example, is the idea of suggestibility that if they hear someone say something, or if they, and we'll come to this later, they see it online, they see somebody ticking in a particular way online, that they will adopt that style of tic or repeat those words in their own vocal tics. Is that what you meant by suggestibility? Yeah.
I mean it in two ways. So tics are suggestible in that if you talk about them, it makes people more aware of the urges and then it brings them on.
Right.
In functional tics, I think more so than Tourettic tics is that they are far more suggestible in content as well. So yes, and this is one of the things I think that's gained a bit of attention in the media and research is it TikTok that are causing these tics? And I think that's extremely kind of simplistic to suggest TikTok would cause this. However, they are very suggestible. So if your young person has tics, it's probably not a great idea for them to be scrolling through social media watching other people with tics, because they will often adopt the tic that they see. And that can be a problem if there's really severe, self-injurious tics, for example. So it's kind of best to stay off of social media, basically, or at least not watch things. So go on social media where it's more written and chats and things like that, if that makes sense. So
Yes.
You still have support, but you're not watching and observing tics.
Yeah, such good advice. And one of the links, I suppose, is that in lockdown, and you're in Sydney and I'm in Melbourne, and listeners, wherever you are in the world, in Australia or globally, you will have been affected, obviously, by the pandemic. Every single person was. But one of the things that I noticed and certainly is connected with this epidemic, if we can call it that, is this idea that when you're in lockdown and you can't do the things you normally do, you spend a lot more time on social media. What's the relationship there? You were at a conference recently. What was sort of said, and what are the early ideas about the connection between the online world and the perfect storm of stressors that young people have been through?
I think there's a lot of discussion about it. I think there's lots of theories about it. I don't think we yet know, if I'm honest.
Yeah.
From my perspective as a psychologist and working with young people that have functional tics and that also might be very active online, I think it's mixed. And I want to make sure I'm kind of clear with this, is that I think to say it's all about social media is very invalidating for the young people that have functional tics because of the level of distress. And I think implied in that is a suggestion that it might be put on.
Oh, right. Okay. Yes.
Which, if your whole body is moving in a way that you can't control, and then you have people suggesting you're making it up, that adds another level of distress, I think, to what's going on. However, I think it's complex, social media, because one of the great benefits, and I think some user groups were discussing this at the recent European conference, is one of the great benefits of it, of course, is that it reduces stigma. So it normalizes differences,
Yes.
which is amazing, actually, because we know stigma is associated with so many of the comorbid mental health presentations like anxiety disorders and depressions. And, our young people with tics are just at much, much higher risk of those comorbid mental health presentations. So anything that can normalize and decrease stigma is amazing. So I think from that perspective, social media has been amazing. I think one of the challenges of social media is, and probably challenges isn't the right word, but that with the normalizing, it means that sometimes those tic symptoms can become a really important part of identity. And I think when something becomes an important part of your identity, just in terms of from a therapeutic point of view, you have to think very carefully about, is it something that you want to reduce or get rid of? And for some people, it's so distressing that they absolutely do. And so that's what we work towards. But for others, what they want to do is get rid of the ones that are harmful and hurting them, which is completely understandable. But other parts of it, they may want to hold on to. And I think we're just trying to learn how to work with user groups and also social media around that kind of balance, really. And I don't really have the answers yet, to be honest.
Yeah, it's just really nice to have the conversation, and it's very special for us to be able to speak with you after you've been to this conference, because no doubt it was a very interesting topic and popular topic of discussion and learning and professional development for you and your colleagues. But it's so interesting what you say about the stigma, because I have a 13-year-old daughter, and it was really lovely this morning, just before we headed out the door to school. She said, "What are you up to today, Mum?" And I said I was doing this interview with you and what it was about. And she said, "Oh, that's Tourette's that you're going to be talking about?" And I said, "Yeah, well, that's certainly part of what we'll be talking about." She goes, "Oh, yeah, she knows about it." She didn't have any other questions. It was really lovely that she even asked.
Yeah.
But there's just this, like you say, about this reduced stigma. I think one of the beautiful things about social media is this openness that young people have who are online to learning about the different lives of other young people who I never had access to as a child growing up. And yeah, it's just a non-issue for them. They have an interest and a curiosity, but there's no judgment. It's really, really lovely.
Yeah. And I think the more young people see diversity and connect with it means that some of the really awful parts of difference in terms of social pressure and misunderstandings can kind of be managed, really, and normalized. And then hopefully all those kind of mental health and well-being factors that impact on young people because of misunderstandings and stigma isn't such an issue anymore. And I think about lots of my young people that I work with tics and Tourette's, and to be quite frank, if the tics were the only thing that they had to deal with, life would be a lot easier, I think. And a lot of what they struggle with is still around shame and acceptance and all of that stuff that comes along, particularly in the teenage years. So yeah, I think anything that we can do, and the young people are doing themselves, sort of outside of the adult world, to be honest, of managing stigma
Yes.
and accepting diversity is a good thing.
Especially in the classroom, I can only imagine that ticking in the classroom is going to obviously draw attention because they're verbal and they're movement tics, and so they're obvious to other people. Of course they are. And so when a class is not distracted by that, not paying attention to it, they obviously at first there's that curiosity in what's happening, but once there's that understanding, and I watched a video of a young girl who was recording herself in her classroom, and in the background were her fellow students just going about their thing, and she did actually tick and reach out and sort of knock the girl beside her, and she said, "Oh, I don't want to hurt you," and there just seemed to be this acceptance, and she was saying that makes a big difference to how she experiences her tics when there is that level of acceptance. Nobody's too fussed about it, because it no doubt reduces stress.
Yeah, absolutely. And I know your podcasts are about anxiety. One of the key things that increases tic frequency is anxiety. And so if you're in a situation where you're feeling anxious about ticking, you're much more likely to tic. And so anything that we can do to decrease that is going to be great. And I think in the classroom, it can be tricky. Some people's tics are not actually that noticeable, especially if they've got motor tics. Kids won't notice, and particularly in the younger primary school years, kids they have no idea. They don't seem to pick it up, to be honest. But it's by the sort of year 7, year 8, year 9, particularly if the tics are persisting, and particularly if they've become complex or loud, it's more challenging in the classroom. And if people are looking, obviously it increases anxiety. If people feel like they're going to be bullied or teased, it increases anxiety. But also just being watched, it makes you more aware of your body, right? And so it increases tic frequency. So anything that can kind of normalize it and decrease it is always positive. And to be honest, I would say a lot of the kids as a general rule are pretty good with it. Some of the teachers are still learning as well, because of course they didn't have the same understanding or learning when they were growing up or going through education. So it's not uncommon for kids to have other kids stand up for them when a teacher tells them to be quiet because they don't realise it's a tic. Often there'll be mates that say, "Oi, he's got Tourette's, leave him alone."
Oh, wow.
And it's,
yes.
It's lovely.
Yes.
The kids feel supported. And then, of course, the teacher didn't realise that it's not like they were trying to pull them out, but there is that kind of support in class.
Oh, I love seeing that. Young people are so extraordinary, and so I love that we've got this opportunity to give them that credit, but also to acknowledge that it's really, really tough. And I wonder if you could start to talk to us about what can be done. What are the treatment protocols? What would you say to a family who's just at the start of this journey, and where does that journey take them as they look for help?
So it depends a bit on whether we're talking about functional tics or a tic disorder, so a chronic tic disorder like Tourette's. I'll start with Tourette's or chronic tic disorders. I guess the first question is how long has the tic been around, and is it problematic? Because as you've just said, for parents, things can be more distressing and problematic than it is for the child. And in terms of the guidance for intervention, I usually say, look, one, is it impairing? So is it impacting on everyday life? Is it distressing, or is it causing pain or injury? And I think those need to be the criteria, because there's plenty of young people with tics in this world that never come into clinical services because it's fine.
Yeah.
And it's not problematic for them. And as adults and parents, we need to be okay with them having differences and kind of getting on with their lives. So I think that's the first kind of, I guess, recommendation. I think a lot of young people grow out of it. So depends a bit on the research, but by and large, 70 to 80% of young people will either grow out of tics by middle to late adolescence, or it won't really be an issue. So they might have mild tics in adulthood, but they're not that observable, or they're not problematic, or they're not impairing. The question is this 20% of young people where it persists and it's problematic, and even for some people it worsens. And I think those are the ones that we're talking about what do we do and how do we help. And really, there's two evidence-based interventions at this time. There are some others I can talk about, but largely the two main ones, and the first line of treatment is a behavioural intervention. And the behavioural intervention is called comprehensive behaviour intervention for tics, but there's two types of behavioural interventions. One's habit reversal, which is where you teach the young person to do a competing movement to their tic. The other is exposure and response prevention, where they learn to suppress all tics at once, so they don't do one at a time. I tend to do the second because I think it's much more effective and easier for young people than habit reversal, but I will do a bit of habit reversal. But it doesn't fix tics. It's not a cure. It reduces frequency and, I think more importantly, increases control. That's one intervention, is behavioural. The second is medications. So there are medications that are available. They have a similar level of effectiveness to behavioural interventions. So once again, they very rarely get rid of the tics altogether, but they might reduce their frequency or intensity. In terms of how people access it, the first point of call is usually GP.
Yes.
And in Australia, a lot of the support will come through paediatricians. Most young people won't end up with a paediatric neurologist unless it's quite severe. So most of the support will come through paediatricians, occasionally psychiatry, but once again, there's very limited services in psychiatry. So the usual course is to go to GP and get a referral to paediatrician or to a psychologist that works with young people with tics.
Yes.
It's sort of the same pathway. So obviously you need to see a GP, and they will often, it depends how complex the presentation is, to be quite honest. So some paediatricians will request a neurologist assessment, but there's such limited availability of paediatric neurologists. And so I have paediatricians that often refer to me for young people that have functional tics, but it's difficult actually, if I'm honest, to find services.
Okay.
The Tourette Syndrome Association of Australia is a national charity who are amazing, and they do their best to support young people all around Australia, and they will signpost. So they have a list of clinicians that work with young people with tics. They have loads of resources. They run camps, they have support groups. They're just a really good kind of first point of call, particularly once you might have the diagnosis. So I think we do have some ideas about how to work with this population in terms of functional tics. So the behavioural and medication for chronic tic disorders that I was talking about has a relatively good research base. I mean, behavioural intervention's been around for 50 plus years.
Yes.
So that's got a relatively good evidence base. When we're talking about functional tics, I think we're building our evidence base, and that's part of the work we're doing at UNSW. And so I developed an intervention called ICBIT, which is an integrated cognitive behaviour intervention for functional tics. And it uses the behavioural components of CBIT, but it uses also a kind of broader cognitive behaviour intervention that recognises the role of the stress system in functional tics. And so we are doing a 10-session intervention at UNSW, and it's something that myself and Professor Valsa Epen, who is a child psychiatrist, have been working with for a few years now. And we've had really good outcomes, and we're hopefully going to publish on them. And in fact, I would say in terms of functional tics, we probably get better outcomes in terms of tic reduction. So for some of the young people that I have done this intervention with, the tics have gone away completely.
Wow.
And so we are getting outcomes, but we just need more research, and we need to, we'd love more funding. It's just a longer term project, really.
It is a longer term project, and I do hope that you can secure more funding, because the distress of children and families depends on this continued wonderful work. One of the things that's coming to mind is that there may be a family listening whereby they're like, oh, that 10-session program sounds extremely promising. You said you're getting promising results from it. And they're probably asking themselves, well, how can I access that? Can my psychologist access that? I know that it's not published yet. Would a psychologist who was working in this field have access to the program to put into practice with their patients, with the understanding that it's not been in play for a long time, but that your anecdotal evidence and your scientific body of evidence is building. Is that a possibility?
Yeah, well, absolutely. That's what we're aiming for longer term. So at the university, we are setting it up as a training clinic for trainees coming through clinical training. For those that are already out there working as clin psychs and will have knowledge and experience of functional movement disorders or functional neurological disorder or relatively similar presentations, really the aim is that we can get this model out there and provide guidance on it. With the 10-session intervention that we're doing with UNSW, my view is for these young people that 10 sessions probably is not enough, but it's all that we can provide. And so that the idea is that we would provide a specific phase of the intervention and then we discharge to local care or their psychologist, and happy to have a case conference with them to discuss the future steps. But lots of the clinical psychs out there will have amazing skills to work with these populations, but perhaps just need some, we need just some guidance and evidence around the very particular symptoms that we're talking about.
Within the realms of your professional expertise, what are the pros and cons or some of the risks for families to consider versus the benefits when it comes to medication? Because I know that it's a really big decision for a family with a teenager who might need this extra help.
So the medications for functional tics, if there is no tic history and it's not considered to have any kind of underlying tic disorder, tend to be more focused on the stress and arousal system. So things like antidepressants or something called SSRIs. And they come with all the usual caveats around side effects and things that will come along with medications. It is kind of outside my area because I don't prescribe. But sometimes, to be honest, if the young person is so impaired that they're needing to present to emergency department, it might be that it needs to be considered alongside therapy.
Yes.
And I always say to parents, you don't need to think about medication as a long-term intervention. Sometimes it's just so the young person can access the therapy.
Yes.
Because their level of distress is just managed at a level that then they can engage. So I think that that's the functional tics. With chronic tic disorders or Tourette's, medication is usually only considered once behavioural interventions have been tried. However, because there's so few people doing behavioural interventions, sometimes medications will be considered. But it's not given to every young person, and there's a whole variety of medications that are considered, including non-stimulants. One of the concerns sometimes is that because there's a high comorbidity between ADHD and Tourette's, so about 60-70% of young people will present with both. And there used to be a concern that stimulant medications that are used for ADHD will trigger tics.
Right.
There's now not good evidence for that. And so although paediatricians or psychiatrists may not prescribe it as first line, I think parents should have discussions with their paediatricians about any concerns they have about that. But it's not a reason to not treat ADHD or, I guess, symptoms that the child might be finding quite distressing or problematic for them.
Thank you very much. I really appreciate that. And I think it's really nice perspective to go, like, this doesn't have to be forever, but this is important. This is potentially important and helpful now to, like you say, help the teenager, help the young person access their therapy, have a little bit of space, reduce distress to be able to really learn what can make a difference. So thank you very much. So how can people connect with you and learn more about your work? You have a website, of course, or look at the work that you're doing through UNSW.
Yeah, so I do work in private practice. However, probably like a lot of people that are working in this area, my wait list is very long, and actually I've closed it for the minute just because it's very hard for people if they're sitting on the wait list for 9 months plus. It's not to say I won't reopen it, but at the moment I'm not. As I said, the Tourette Syndrome Association of Australia does have a list of other clinicians that work with young people with tics, so they're worth contacting. Our clinic at UNSW does take referrals, but of course we're a very small clinic. So, I mean, it's me and a trainee and a psychiatrist that has very limited time. 1 day a week. So the referrals would need to come in through a paediatrician or neurologist. I mean, we will occasionally take it through GP, but really we like it to be through paediatrician and neurologist to make sure this is the presentation that we're talking about. It's basically called Tic Clinic at UNSW, so it's Tic Clinic at unsw.edu.au.
Thank you very much for your time today. Honestly,
No
I know
problem.
that you've really carved out an hour for us here today, and we're all very grateful because this is an area that is frightening and a bit tricky to navigate, and just episodes like this can really help people to feel like, right, I have a good understanding, I'm on the way to getting the help that I need through some of your recommendations as well. So thank you again.
No problem. Thank you for having me.
Thank you. And thank you, listeners. Thank you again for joining me. Be sure to follow me on Instagram at Dr. Jodie Richardson, and I will put all of the notes, all of the details that Dr. Amanda Maxwell shared in the episode in the show notes. Until next week, have a lovely, lovely rest of the day, and I will see you next week. Okay, bye. Thank you so much for joining me for this week's episode. If you enjoyed it, please subscribe and leave a review. To keep the conversation going, I'd love you to join me over on Instagram. You'll find me at Dr. Jodie Richardson. Also, if you'd like a copy of my free 5-day mini email course, Calm Your Anxious Brain, then jump over to my website, drjodirichardson.com, and you can sign up down the bottom. I've really enjoyed having your company. Thanks so much. See you next time.